Good morning. Steve Stites, Chief Medical Officer of the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio. Delighted to be back with you on this Monday morning after a tumultuous weekend and no Chiefs game. But fortunately, hopefully, keeping our fingers crossed, they're going to be playing tonight. We've got some great guests with us today. We're going to start, of course, with Hawkeye, but on my left, the Chancellor of the University of Kansas, Dr. Doug Girod, good friend, and Chris Wilson, VP of System Integration, or some long title, integration, I don't know, innovation, smart people who work together, get things done. That's Chris Wilson. And Chris has done enormous work for us, working with KU and Lawrence to keep the campus safe and reopening. And boy, I think these guys have just done a great job in Lawrence. But first, Dana.
Yeah.
How's it going this weekend? The numbers still a little concerning.
They are concerning. You know, selfishly, I do like the prospect of being able to watch the Chiefs after a hard Monday. So
okay, well,
pretty nice.
That's good. As long as everybody stays healthy and everything's COVID-19.
Yeah, absolutely.
Yep.
So the numbers are concerning, I think, both in the Kansas City area, because we have seen an increase in our rolling 7-day cases, but certainly here at the health system, it's even more concerning. You know, a week or 10 or 14 days ago, we were at about 50 total patients in the hospital with the acute and the recovery. Today, we are at 32 patients in the hospital, and I think we are at 1.35 in the hospital for the acute infections, and we do have 30 who are in that recovery period as well. As far as those acute infections, we do have 11 in the ICU and 8 on the ventilator. So that's 70%. And last week, it was about 70 to 80% on the ventilator as well for those in the ICU. So those are not good numbers. In addition, we know that our partners in Hayes last week had fewer cases. I think they had about 14 with 1 in the recovery period. Right now they're sitting at 19 acute infections and none in the recovery period.
And we're seeing that trend across the country as the rolling 7-day total continues to rise throughout the United States. So not a surprise really that we're going up as well. But it feels like that's probably a combined result of a lot of different things. People getting tired and doing stuff. It's getting a little chillier, so folks starting to go back inside a little bit more, and maybe inside restaurants, which we know can be a problem.
Yes.
And then also just having campuses, schools reopen, and Labor Day, and on and on and on.
Yes.
Thoughts?
Yeah, and I think this is that time point when we talked about Labor Day, where it does take those 2 to 3 infection cycles, so those 14-day incubation periods, to really start to see. And we know hospitalizations lag behind cases, and we know deaths lag behind hospitalizations as well. So that is all kind of consistent, although we would like to see fewer and fewer. That's not the case right now.
Yeah, it's been a tumultuous start, but it's been really important, I think. Some campuses have done a great job of reopening their campus. Dr. Girod, I'm going to count y'all as part of that because I think KU has done a great job. Talk to us a little bit about how KU has reopened, how they're trying to keep students stay safe, and so what are some of the unique aspects that KU has done that others have not done?
Well, I think, a number of answers to that question, one of which is certainly how we've reconfigured the campus and our curriculum so that we really de-densified campus very aggressively. Obviously, we redid all the classrooms for social distancing. People have been doing great with the mask mandate, wearing them inside and outside, doesn't matter where you are. If you're by yourself, if you're on campus, you have a mask on. People have been really good about following that protocol as well. But I think the key was on the front end, being able to do that mass testing, of reentry testing, and identifying really hundreds of cases of folks who are coming back to campus, coming back to Lawrence from elsewhere, all across the country, and being able to identify those folks and get them isolated at the outset, and then keeping up with that. And of course, we've finished that entry period. We actually started our 7th week of classes, which is hard to believe already, which is great. But we've made that shift now from that mass entry testing to more of a prevalence testing model going forward, and we're learning from that as well. But trying to keep an eye on what's happening within our community, and for better or worse, we're also seeing I think an increase in the number of folks symptomatic testing, which we're doing as well. So trying to track all of that.
Yeah, and if I can interject, certainly we have seen that other college campuses have gone away from in-person learning. I think you and the staff have done everything they can do, and this can be generalizable to even local elementary and high schools too. you have done an excellent job of creating those systems and having those things in place, like you said, de-densifying. Obviously, some local schools will be easier to do than others, but really on campus, you've created that safe environment. It's in the community when there is the problems or where that higher risk is for spreading the disease.
Well, I think that's really true. I don't think our risk is on campus. Our risk is off campus for all of us. I mean, it is whether you're in the grocery store, or you're in the restaurant,
absolutely.
or where the hardware store, wherever you are. That's probably a higher risk right now than actually everything that we've got in place on campus for our students, staff, and our faculty. And actually, the prevalence testing that we're doing is looking at a pretty low rate right now, which is good. And while we're continuing in Douglas County, continuing to see number of cases per 100,000 creep up just a little bit. Really, we're in somewhat of a steady state, I think, right now. And I might even ask at some point Chris Wilson to comment on that.
We're going to,
in
for
our
sure.
forecasting model around that.
So, Chris, let's talk a little bit about that. I know that you have worked with the KU Lawrence team and the health system team, the KU Medical Center team, to help build a model to kind of forecast what's going on at KU in terms of the number of people who are positive, predicted outcomes as far as hospitalizations, et cetera. Walk us through that a little bit. Where are we? How's KU doing? What's the model predict for the coming weeks?
Sure. So we've got about 1,000 cases to date for all the testing that we've done on campus, which is pretty much in line with where we've expected to be at this point in time. Positivity rate is about 3.5% to date, and then the campus released numbers also last Friday for the last 7 days, and there you see pretty consistent themes with positives and positivity rate consistent with our dashboard and our forecasting efforts. So. We're running about 5 to 10 positives a day for the population on campus. Again, between a 3.5% or 4% positivity rate, as you can see on the screen there. The symptomatic test, or excuse me, the prevalence testing for those asymptomatic individuals is running right around 1.5%, which is a good number that we like to see there to be able to identify how much spread is happening among the campus involved in the prevalence testing effort. On the symptomatic side, we get about 30 to 35% positivity rate when you look at the testing that's occurring at the Watkins Clinic and also the new health system swabbing clinic there on campus as well. About 2/3 of our positives right now are symptomatic, 1/3 asymptomatic. Which is, again, an indication of where most of the kind of activity in the spread is that we're catching on campus at this point in time. We've developed a forecasting model that we released a couple weeks ago to look and see what we project the cases to look like over the next 2 weeks. And we're really staying pretty close in line with what that forecast is projecting. So 2 weeks ago, we were projecting about 6 new cases a day. The prior week, we projected about 10 cases a day, and then the one that we released last week projects about 6 new cases a day 2 weeks out. So we're just staying pretty consistent, as you can see on the screen there, of where the model is projecting cases will be, which is really important because that helps us indicate how much resourcing we need to devote, any changes in interventions that we need to do on campus, any additional staff swabbing resource that we might need to deploy to the campus. So continuing to stay consistent with where we projected cases will be on this rolling 2-week basis.
Pretty good. And just to say, the overall prevalence rate, if you're not symptomatic necessarily, you're running around 1.5%. It's pretty, Dane, I think that's kind of close to what we think the population probably is.
Yeah,
right?
certainly.
If you're just going to do prevalence, I think it's 1 to 2% of any people are positive at any one time right now, and the virus continues to spread.
Yeah, and that's why more testing is so much more important. He did make that very good distinction of they are having a lot of high percentage positives, but those are for symptomatic people, so you would expect those to be positive. But in general, absolutely what you said is 1 to 2%. And that's why for the mass population, we certainly want more accessible testing for everybody. on a more frequent basis.
I'd like to just give a quick
Chancellor.
shout out to Chris and his team for helping us get in more symptomatic testing capability, because we were stretched at Watkins to manage that volume, and in a pretty short period of time, Chris and his team have stood up another drive-through swab testing clinic for us to be able to really more than double our capacity to meet the need on campus, and that's been really effective. But that's helped us take that shift from, resources for entry testing to resources now for ongoing symptomatic testing as we need it. Of course, as we approach flu season, certainly concerned that demand is going to go up, trying to sort out what's COVID, what's flu. So I'm sure those resources are going to be in high demand.
Yes.
Chris, thoughts? You look like you're about to say something. I know that
Well,
face.
yeah, I appreciate the comment. And also to note, we've got healthcare needs for the campus population that existed pre-COVID that we also can't forget about. And so I think it's important that we can add these additional resources to the campus to help manage the COVID needs, but also not only flu, but also the variety of other, acute or chronic conditions that may come up along the way from a typical semester on campus. And so being able to free up the healthcare providers on campus there to make sure and allow them to serve those patients' needs as they would need to do in any other semester is critically important as well. And so a big shout out there to the Watkins team, Dr. Sarah Polly, Diana Mott for their efforts and engagement, making sure that happens.
Yeah, good work there. And so, Chancellor, have there been students who've had to be hospitalized or been sick directly from COVID-19?
To our knowledge, I don't believe we've had a student hospitalized at this point in time. I'm sure there's some that have made a visit to the ER for checkup and testing and everything, but to our knowledge, we've not had anybody hospitalized.
And I believe there have been students who've come through the ER with COVID-19, but usually for other reasons, and they found COVID-19 as part of the testing. I think, Chris, you can probably help me verify that, or Hawkeye. That's what I know. That's what I call the story's been.
Right.
So, yeah, good. Well, we were hoping the campus stays safe. I think it's an American success story, quite honestly, of how we can do this well and do it right and keep education open and even keep campuses open. There was an article last week, I don't remember where I read it, but talking about look at these great schools that have tested everybody and keep testing, but they're all like colleges of 1,000 or 3,000 or something like that, not 30,000. I mean, there's a scale difference here that we have to appreciate.
There is, and I'm just really proud of the team and how everybody's pulled together to do this, and certainly it's been a very collaborative effort with Lawrence Memorial Health, with University of Kansas Health System, and then our incredible team at Watkins, as well as our operations team, to really pull all this stuff off, and so far so good, halfway through the semester, and I think feels kind of like we've reached a little bit of a steady state. We know the wheels can come off the cart at any point, but really people are doing all the right things. The community, the city, and the county have been phenomenal partners to help us, recognizing that what we do influences their community as well. And I really think it's been obviously a very collaborative effort, but so far at least I think as successful as it can be. I mean, we can't get rid of the virus at this point in time. It's really a matter of how we do what we need to do with it in our presence.
Yeah. All right. Well, let's turn and first see if there's any questions that are out there from media. I'm not hearing any, so Jill, I think we're up.
Yeah, we have a ton, both on and off topic. I'll start with the on topic questions first. Debbie wants to know, do you plan, she said it may be kind of early to talk about it, but after the winter break, are you going to do pool testing, mass testing again? What is the plan?
That's a great question.
It is a great question. It's in conversation right now. I think, to be honest with you, I think testing technology is changing pretty quickly right now.
Rapidly.
So we may have some other options about how to do that. We're also going to have to figure out what to do with all those folks who have already tested positive as we come into the spring. But I think the answer is yes, we will plan on doing some mass testing of some version. We just got to figure out what the right format is, and we're going to need these guys' help to figure out what the data is telling us as that'll be February 2nd that we start back, and a lot can happen between now and February.
Well, it really can, and you'll still be in the influenza season, and we have to be thinking about that. And we don't know what new therapies are going to be available back then, or what even vaccination may be out by then. So we'll see. It'll be interesting.
We have even
time.
one of our own faculty is developing a 5-minute on-the-spot test. If we have that capability coming into next semester, the testing may actually look very different in terms of even our prevalence testing.
Which would be great. 5 minutes 5-minute
Wonderful.
on-the-spot test. Can I get it to be like a home pregnancy test? Because that's what,
Right. Have everybody
Yeah.
get and test yourself in the morning. That would
Yeah,
be the ideal
that
thing,
would
right?
be
That
good.
everybody could do a spot check and before you come into work or to school or whatever. So that would be the ideal scenario. As we know, more testing is the way to go. We
Yeah.
aren't there yet,
Yep.
but by February we could be.
Yeah, it is changing so rapidly. That is certainly, go down to Walmart or Walgreens or CVS, buy a case of these home tests and do it once a day or once every other day and get that to understand, number one, if you have it or if you're infectious. That is the other theory behind that. But to your point, talking about reinfection, if you've already had it once, that is a huge topic. There's not a lot of guidance on that. We are still learning more. We are seeing possible new cases or new reports on a daily basis. So that is one thing that we are working towards figuring out right now. We just don't have the answers.
Right.
Jill?
Okay, so Donna's worried about students that are off campus, and she talks about a friend who had a student that was quarantined twice, and mom and dad run food by and that kind of thing. And she's wondering, what about the kids that have to quarantine and they don't have somebody who can run the food by? Does the campus get involved in that at all?
So this has been the big challenge. So let's talk a little bit about the off-campus, on-campus dynamics and how it's been different, whether you're in a Greek society or living on your own off-campus.
Well, certainly, on campus is the environment we have more control over, and so we have created quarantine and isolation space in Naismith Hall and in one of the other dorms as well. So to really accommodate the folks that we need, the number of students that we need for on-campus housing. The reality is we've not needed that full capacity, so we actually have opened that up to some others just last week to allow some of the off-campus people to have access to that as well. And of course, we provide food for those folks. But for the broader Greek community and for students in houses and apartments, et cetera, across all of Lawrence, we actually don't even know who they are or where they are, to be honest with you. So we have a food pantry that is available. The city does as well, and to help out. And certainly Watkins continues to provide healthcare services for all those folks.
And Chris Wilson, you're a member. You live in Lawrence. Talk to us about other thoughts you might have about this question.
Well, and we may all be benefiting here from some of the advances in food delivery these days. So I know, services like DoorDash or Uber Eats are pretty prevalent in college towns and here in Lawrence as well. And I know that's another option that a lot of individuals that have been in quarantine have taken advantage of from a food delivery service that's safe and keeps folks from mixing with others in the community when they're in that quarantine period.
And Chancellor,
Which includes grocery stores, by the way.
Yeah.
So.
So one of the questions, I think one of the things we say to students, if they're positive, is you can go home to quarantine. So do you have a sense of how many students are going home and go to quarantine? Any thought about that?
I think so. About 40% of our students are out of state.
So they can't- well, unless they're-
for them to go home is
yeah.
tough, right?
Yeah.
Right. But for those that are in-state students, a lot of them do go home, and we see that even from the dorms. Actually, they have the choice to go to Naismith, but some of those students are choosing to go home to do their quarantine as well. And we certainly, I know, we're seeing that a lot in the Greek community as well. That those students are headed home. I think we don't know entirely what's happening for all the students that are off campus.
Yeah. Well, there you go. All right, Jill.
Donna wants to know, what is Douglas County's positivity rate? Is it higher than yours, KU, I'm assuming she's asking? And if so, does that reflect that testing efforts aren't extensive enough to catch the cases? What does that mean?
It's a great question. Why don't you ask Chris?
Yeah, I was going to say,
Chris
Chris
has
has
been
got
kind
a
of
better
zeroed in
handle
on
on
that
that
question.
than
I'll
I
let
do.
Hawkeye too. So,
Yeah,
yep.
absolutely. I'll throw it to these guys.
Sure. So Douglas County, at least the last numbers from late last week that were released, was a 7.2% positivity rate. So obviously, several percentage points higher than our 3 to 4% positivity rate that we have on campus, and 1.5% from our prevalence testing efforts. I think the question's spot on. It's likely a difference of which people are getting tested. That's one of the challenges with the positivity rate metric is it can be difficult to compare different positivity rates among one another because the testing programs or protocols may be different depending on the community. And so I think by and large, testing in the Douglas County area has been focused on symptomatic and some close contacts of symptomatics, maybe not quite to the extent, though, that has occurred on campus. Certainly no sort of broad entry testing, mass testing effort like occurred on campus with 20 to 30,000 individuals at a time getting tested. But I do know that Douglas County has focused on increasing testing capacity to the extent they can, weekend hours, making more testing available as possible. One of the pieces of the testing sort of portfolio or puzzle that's out there is what the resources that Douglas County has been able to bring to bear.
Yeah, and I think, Hawkeye, just to say, if you were looking at this on a statistical method, the more people you do in prevalence testing, which is not something the United States has really done. Prevalence testing, which KU has done, really helps you understand what's going on in the community or in the campus at any one point in time. But if you don't do that in the community and you're really only testing more positive patients, you're going to have a higher positivity rate because you don't have as many negative tests to throw in there.
Correct.
Which is what happens with KU. Again, prevalence testing makes a difference because prevalence testing helps us understand how the campus is doing as a whole.
Yeah, absolutely. If you were testing only symptomatic people or people who have been in close contact with known cases, you are likely going to have a higher chance of having a positive. We don't really have a good mechanism here, either in the United States or locally in our communities, for prevalence testing, just as you said. And that would be one thing that we would hope to get to in the future, more for the mass population to really understand the dynamics there. So
You're right.
I was just going to add that I know Douglas County is, as Chris mentioned, working on increasing that availability of testing much more broadly to the community. They got some of the Sparks money from the feds to the state to Douglas County to work with Lawrence Memorial to really convert that testing site that they set up for us. They tested all of our faculty and staff through Lawrence Memorial. They're going to convert that to community testing and try and make that more available. So hopefully in the weeks ahead, we'll see a higher availability in the community to match what we're doing on campus.
Jill.
All right, so now we're moving into a group of questions that have to do with the president and his medications. Then we have a group of questions on colds, and we even have one Patriots question. So the presidential questions have to do with, let's just start with, can you speak to all the antivirals and the medications that they are giving the president? What are those and how are they used?
Yeah, I think, Hawkeye, you and I could probably take this on. The reality is most of the things he's had are standard of care for people who are hospitalized and more acutely ill. That includes remdesivir, steroids. I'm going to bet he got Lovenox as well.
I would think so.
And so those three things are things that we would give patients if they were in our hospital.
Correct.
What he didn't get is convalescent plasma, because convalescent plasma has antibodies in it. That's really why you get it. And what he did get was a drug that's not available to the general public called Regeneron. Regeneron is a drug that's undergoing a clinical trial. I think that they've said, well, it's available for compassionate use. I'm not sure that that's a completely accurate statement. I don't think if somebody was in our hospital, we could obtain this Regeneron drug, which is really monoclonal antibodies. That is, antibodies that we have developed that are used by your body to try and attack SARS-CoV-2. But we can now make those antibodies without having to take it from the serum of patients who have had it, and that drug is by a company called Regeneron. There's another drug similar that's one from Eli Lilly. The one from Regeneron actually includes two different antibodies. That drug, I don't think that's available for compassionate use to the general public. I'm not surprised that the president got it, honestly. And I think, and as we've said on the program last week and the week before, we think in the long run, these drugs, like the one from Regeneron and the one from Eli Lilly, if I can speculate and not be a scientist for just a moment, I'm going to say that those drugs are going to actually be really great therapies for COVID-19, but they're probably not going to really be available until after the first of the year. So, thoughts?
Yeah, absolutely. And we talked about this a little bit on Friday when we found out he was positive. Certainly, if my parents were diagnosed with it today, I would want them to have remdesivir. Yep. And I would want them, even if they are not in the hospital, and I would want them to have either the convalescent plasma or the Eli Lilly product or this new Regeneron, any type of that sort of convalescent plasma or monoclonal antibody product. It's certainly very understandable that the president got that. Unfortunately, there is no real outpatient treatment plan for SARS-CoV-2 as there is for influenza. If you have influenza, you can obviously get Tamiflu. We would like some sort of oral medicine for that. When you get diagnosed, you get that to really help to stop the virus replicating as soon as possible. And then, just as you said, the antibodies, the monoclonal antibodies, are going to be very important to really give your immune system a chance to catch up to the virus. So I think that's all reasonable. Again, we did find out he was getting steroids, and he probably did get anticoagulation too. That's an extremely important part of the treatment algorithms.
And would you get that to anybody who came in the hospital, or do you have to have a certain degree of acuity of illness in order to get those?
Yeah, for the steroids, we do have to have criteria for that. That is telling us you probably are desaturating, meaning your oxygen getting to your tissues is not optimal and not what it should be. We know that if you don't need supplemental oxygen, or if you don't have those low oxygen levels and you get steroids, it could actually be harmful. So there are criteria to get steroids to really maximize that treatment.
Yeah, so my guess is he actually did desaturate a little bit. They gave him the Decadron, probably appropriately so. They gave him Lovenox, appropriately so. They gave him Remdesivir, appropriately so. To me, the only one that's really in question is the use of Regeneron. He's the president. He got an experimental therapy, but I question whether it's really available for compassionate use for all folks.
It's just too soon in the clinical trial process.
It is
that
too
what you're
soon.
saying?
Exactly right, and we just don't know enough about it yet. And so, whereas I think it's going to work. You know, we had Mario Castro here in the clinic or in the program on Friday, and you know, we're doing the Eli Lilly study on a monoclonal antibody, and he said, you know, it's probably not hard to figure out who got the drug. It's, you know, just double blind. You don't really know. But when people do really well with something, it's not hard to figure out that they got the drug. And I think that's what we're going to see with these monoclonal antibodies.
Can you talk a little bit more about the dropping of the oxygen levels? What's dangerous?
Yeah, you know, we don't really have specifics about this, so we can't say what happened with the president.
Not for him, but just in general.
Yeah, I'm going to get to that. So, you know, we follow blood oxygen levels all the time in the hospital. I mean, that's a pretty common thing. And when you come in and you're hospitalized, I'm going to guess they say that he was short of breath, so he probably had. And nobody's talked about his chest X-ray that I've been able to see.
Imaging.
So my guess is that he probably has some infiltrate on film, which is pretty common with COVID-19, and that means you have inflammation in your lung, and when that happens, your oxygen levels drop. When your oxygen levels drop, that's your O2 saturation. Really, we look for anything below 90%, and we start saying, okay, you're dropping below normal, because, you know, by all reports, this is a guy who doesn't smoke a lot, doesn't drink a lot, doesn't smoke, doesn't drink, and is pretty active in golf and moving around stuff. So he's probably got pretty good lung function, and he probably gets out and he probably has pretty normal oxygen levels. So for him to drop his oxygen level would be when we would give people therapy, and I bet that's exactly what happened. Dangerous is a hard thing to define, because the pictures of him are always without oxygen, suggesting that he doesn't need it, but he has periods where it drops and then it bounces back up again. Again, that's pretty common in disease and certainly common in COVID-19 data. Yeah,
and I think to your point, we know that people who don't have any symptoms at all have changes in their chest X-ray or their chest CT scan showing inflammation. Yeah. And you know, a lot of early reports are people will come into the hospital and they will have oxygen saturations in the 60s or 70s and not even feel very ill. Their heart rate is racing. But it's really different from other entities where we see when you have that low of oxygen in your blood, you really are short of breath. And that was one of the very interesting things, especially early on when we saw patients in the hospital about that.
And Craig has a question about shedding the virus. He saw the president driving around, and he's wondering if he's still considered contagious. And he also followed up with, if you get it a second time, do you shed like you did the first time?
Yeah,
which is unrelated to the president.
So the first question is, he is still shedding the virus actively because he's so early in his infection, because we knew he was negative one day and then positive the next. So he's pretty early in the course. So yes, he is still shedding the virus. Can you shed it the second time, and how much? I think that we don't really know the answer to that yet, Hawk.
Yeah, absolutely. We know that you are most infectious and shedding the most virus probably 1 to 2 days before symptoms start to 1 to 2 days after symptoms start. And then it goes down from there, probably really to about 8 days. And that is why the CDC guidance really is, if you have symptom onset, you really need to isolate 10 days from that symptom onset, because by that time you are really very significantly less infectious. So that is why it's that 10 days. But unfortunately for the reinfection, we just don't have a lot of those answers. And hopefully moving forward these next few months, we will get those answers. Not only are you still shedding it, you probably still are shedding it, but how much? Is it the same amount? Is it less? But also individually, what are your symptoms going to be like? Are they going to be less because you have some immune response? Or could it be the same as it was the first time or more? We just don't have enough information to draw a broad picture like that.
Tony wants to know if antivirals help with pneumonia.
It all depends on what kind of pneumonia you have. And so antivirals are very specific to certain viral illnesses, and so it really depends on what it is. And by and large, we don't have a lot of antivirals that are truly effective for pneumonia per se. Influenza, Tamiflu, RSV, there's some therapy you can have, but most viruses are not. We don't have a strong antiviral panel about this. Mostly that's true because we all get better from viral illnesses, and we don't need, it's not like an antibiotic in bacterial diseases. Back in the day when you were a surgeon, I guess you're still a surgeon.
So they say.
So they say. I mean, you would give your patients antibacterials if they
Absolutely.
develop pneumonia.
And a majority, or I guess the majority of pneumonias are bacterial.
Yes.
Yeah.
They are.
So it's really on the antibiotic side as opposed to the antiviral side. But in this case with COVID, clearly it's viral in origin.
Yeah. So there aren't a lot of antiviral therapies, Dana, that are out there for this kind of thing.
Right, yeah, just understand pneumonia is a general term for infection in the lung. It can be caused by bacteria, by fungus, and of course by viruses. So it just depends really what is the etiology, what is the main cause of that pneumonia that we would direct our treatment with that.
And most of the time, again, we get better from viral pneumonia, so it's not a big deal. But in
Yeah.
this case, that's not true with SARS-CoV-2, which is why there's been such an effort designed at things to try and improve the outcomes.
I have several people asking about colds and runny noses. Can you give some guidance on what are the questions you should ask yourself, or do I need to run straight out and get a COVID
Well,
test?
that's the question
That is-
right now.
yeah.
Okay, we're just going to see what our panel thinks because I'm not sure we
I'd
have
like
a good
to know
answer to
too,
this
'cause
question.
my husband comes home congested like
Yeah,
every
you
day.
know, here's the problem. We can't really distinguish between some of the allergy symptoms and COVID-19, let alone COVID-19 and a cold, because remember, they're all coronaviruses. Well, not all. There are other common cold viruses like rhinovirus and enterovirus and some of the others. But the truth is that the problem is going to be that the symptoms, especially that runny nose, sore throat, that can all be part of the symptoms of SARS-CoV-2 as well as one of the other coronaviruses or rhinovirus. I think it's really hard to distinguish that, Hawkeye. And then we could say, well, here's some general guiding principles, but they're just general guiding principles that can be totally wrong.
Yeah, absolutely. And, you know, there has been some theory or effort put forth. Well, if you lose your taste of if you lose your sense of taste or smell, maybe more than likely that's leading you down the path of COVID. But we still don't know. We know that people can lose their taste of smell and sense of taste
Sense of
and
taste,
smell.
yeah.
With other viral illnesses. Maybe it is more prominent here because of the collection of receptors for the virus that is in that area, that neurological area. So it is very difficult to tell, to your point, and that is why capacity for testing and access to testing is going to be so important moving forward.
So do you think people who have those symptoms should go and get tested?
I absolutely do.
I do
Yep.
too. And I think the other thing you have to do is you got to isolate. You can't go to work.
Yes.
You got to quarantine yourself just as if you knew you had COVID-19, because otherwise you could be the one who's being the spreader, and you don't want to be the spreader. Spreaders are bad. Not a job you want.
Okay, well, tell my husband when I get home tonight.
Work on him.
All right. So Lacey wants to know, if the earlier the treatment starts, the better, then why aren't people who test positive on outpatient not getting any
That's a
therapies?
great
Great
question. That's a great question. Well, part of it is there's a paucity of therapy. We don't have enough
Correct.
remdesivir to give around. Secondly, the monoclonal antibodies are still undergoing treatment trials, so you don't have that. So then it comes down to steroids and anticoagulation. And the problem is that, let's take anticoagulation. There are side effects of thinning your
Yeah.
blood. And if you started testing people, giving everybody a Lovenox when they didn't need it, which is one of the anticoagulation drugs, you then have to start saying, how many people do I need to treat early in the disease in order to see a better outcome because we gave you a blood thinner, versus how many people am I going to treat and see a worse outcome because I gave you blood thinner when you didn't really need it? And we don't know that answer.
Nope.
And that's a problem. We just have to be honest about that. You know, I was doing a little board review last night and looking at the number of people who you treat for different kind of clotting disorders and how many you had to treat versus how many you had to, how many you treat before you saw an improved outcome versus how many you treated, and they started having side effects like GI bleeding, brain bleeding, joint bleeding, things like that, Hawk?
Yeah, absolutely. That is a huge question. We want to get to a outpatient treatment algorithm, meaning if you don't have to come to the hospital. And like we said earlier on the show, if you get diagnosed, you have something like Tamiflu that you can take for influenza, but you have an oral antiviral that you can take for this, with the possible adjunct therapies of maybe anticoagulation for 14 days or 30 days, hopefully not steroids at that point, and also maybe an outpatient clinic where you can go in early in the course of disease and get those monoclonal antibodies. So those things are all being looked at, but for right now, just as you said, there's just a paucity of treatment, and a lot of these treatments could potentially be dangerous, such as too much blood thinner anticoagulation, steroids given at the wrong time, too early in the course of disease, and then it is otherwise fairly difficult to get remdesivir. It is an IV medicine.
I was just going to add, but there are a number of people who get COVID-19 who probably don't need that level of therapy.
Absolutely.
Right, that's
Yeah.
exactly the point.
Right.
And so you don't. In fact, most of the people stay home. Only a relatively small percentage of people get hospitalized. And remember that once you come in the hospital, the earlier reports that were 30 or 40% mortality, and today our mortality runs around 7 to 8%.
Yeah.
And so the therapy does work, and not being overwhelmed works. So we have to be careful with the therapies, because both Decadron and Lovenox do cause a lot
They
of
do have
side
side
effects.
effects.
And remdesivir, which is relatively benign, isn't that widely available. So you got to save it to folks who are really sick.
Okay, Donnie has one that I haven't heard before. She said, I heard the warm air inside your mask is building bacteria. The air is cold in the doctor's offices and the hospitals, so that's why you don't get bacteria when you're in the hospital and you wear your mask, right?
Yeah, that's just not right.
Yeah.
Sorry. The climate, I understand the thought behind it, but it's not accurate. First of all, the mask, the temperature inside your mask is going to be what you're breathing out, and what you're breathing out is pretty much consistent within a few degrees. Even if you have a high fever, it's really a difference of 3 or 4 degrees. So it's just not the case. The air inside hospitals is cold because that's what makes most people comfortable, and in the operating room, there's some reasons behind that. So we'll ask Dr. Gerard about that in just a moment. But the reality is the temperature in your mask is really your body temperature almost all the time. If you go outside in the coldest of air when it's going to be winter, yeah, your mask is going to be colder, but I wouldn't connect those points. Those points are not really connectable. And so why do you guys always keep it so darn cold in the operating room? I always wondered about that as a patient who had a couple
Also
surgeries.
because we dress in layers. We have gowns and gloves and hats and masks,
All
and
right.
the patients have drapes and tons of stuff stacked on them, and you can
Yeah.
actually get their body temperature up if you don't keep your room pretty cool.
Okay, well, there you go. I always wondered about that because, one of the greatest feelings is going to the operating room. Now, that's not a great feeling. I've had a couple shoulder surgery, and you're freezing, and they bring you those warm blankets. You're like, thank God for that warm blanket.
Yeah.
But I
and then they
think
put you to sleep, and you don't know anymore.
to the point of masks, there was a new study, I believe it was in JAMA, Internal Medicine, one of those, that actually looked at mask use because there was a lot of discussion and thought that it increased your CO2 and disrupted gas exchange. There was an actual, now a published peer-reviewed article showing that does not happen.
Right.
So
We've
wearing
known
the
it
mask does not happen.
Yeah,
So.
we've known that. That was one of those things where we're going to go out and show you that it's true, even though we already know it's true.
Correct. Yeah.
Yeah,
Right.
exactly.
Okay, we had a question about, Maureen wants to know if CV Key works, what you think about it, if you don't have to use it to enter the building, if it's not mandatory to enter the building on campus.
That's a
Is
great
it?
question.
Yeah.
Yeah.
Yeah, well, it is mandatory to use coming in, but we don't necessarily have somebody checking every single door to make sure. And really what it is, it's a symptom checker. It just gives everybody pause to stop and run through your own symptoms and make sure that you aren't experiencing symptoms. And if so, then if you answer it honestly and you do have symptoms, then it will suggest to you what you need to do, which is typically isolate and call Watkins and get some advice. So, but we do have the receivers at every door in the buildings, and we do require it. And in some places we monitor it, but not everywhere.
Hawk, the Chiefs, don't they use something like CVQ? Don't they do a symptom checker thing? I think I've read that.
They have a lot of technology that they're with. Symptom checkers, they have body movement checkers as well, where they can, we had that guy on from Lawrence with the Google too, where you can actually see in proximity who you may
CVQ.
be with.
Yeah.
That's CVQ.
That's the key thing.
So yeah, they have very good processes in the NFL. They've been very deliberate about what they want to do. So I think moving forward, hopefully that we can continue to keep everybody safe.
And we're just hoping that Jordan Tamu, I think that was, I said it correctly,
Yeah.
was not around the rest of the quarterback squad or the offensive coordinators or the head coach or too many other people on the Chiefs for
Yeah.
too long, although he is the practice squad quarterback trying to imitate
Which
Cam Newton.
is different than Cam Newton, because from what I heard from Bill Belichick's interview, he was around everybody all the time.
Yeah.
I mean, he was just, so it's very.
So we'll see. I
difficult, yeah.
still don't know if we know we're going to really play that game tonight.
know.
They have to do checking today. So
Testing today.
there's one more question, Patriots question.
Right. G wants to know,
Oh, sorry. Yeah.
to your point, why aren't the Patriots quarantining?
Yeah.
You know, that's a great
don't have a
question.
lot of answers for
Because
that.
here's my thinking, and Dana criticized me, but really, if the guy's positive and he's been around other players who are
Mm-hmm.
at infection risk, you won't know if they're positive for 8 to 10 days. I
Correct.
don't know. I'm a little uncertain about how, and frankly, I'd say the same thing to the Chiefs about
Yep.
Jordan Tamu. I don't know enough here. I don't know enough of the story of what that dynamic was. Plus, they do test every day.
They do.
And so if you're negative one day and positive the next day, how many people did you come in contact with over that time frame? And there's just a lot of things we don't know.
Yep.
So I'm hesitant to speculate. I think we probably actually know more about the president's illness
Yeah,
because there's
right.
so much stuff going on, and not as much about the Patriots and the Chiefs, really.
Yeah, absolutely. I don't know enough either to be able to talk
Yeah.
about that. But that's a very good question,
It's a
and
great
that's something that
question.
we've thought about as well. So
So I just hope we
But
just
it's
cross our fingers.
A challenge in athletics in general is,
It is.
you know, we're doing the same in the Big 12. We're tested 3 times a week, including 24 hours before games. But this virus is everywhere, and
It is.
and we're seeing that you know, testing rate is low, but it's not zero. And so we also really have to have, and hopefully they did have, things in place where you don't have a lot of direct contact, except when you absolutely have to.
Yeah.
So that minimizes that exposure if somebody does test positive.
and now we have a extremely good example and well publicized example of a quote unquote super spreader event.
Yes.
So it is out there, just as you said.
Okay. All right. So final thoughts from the day. Chris Wilson, final things. What are we going to do to keep KU safe in the future? Thoughts about that or our next steps there in Lawrence?
Yeah, my biggest priority right now is to not let up. So we are about halfway through the semester, as Dr. Durrad referenced, and relatively strong work and results so far. But we're only halfway there. So I would just encourage everybody to do the things that you mentioned on this program every day, Dr. Stites. So continuing to adhere to their infection prevention protocols and practices. So masking, distancing, coughing into their arm. And making sure that they are on board and can finish the semester strong as we started it.
Chancellor?
Well, I think what we learned as we started out this semester, we've now, we did not have fans in the stands or at the fields for the month of September. We just had our first home football game on Saturday with 25% occupancy, and it went really well. I mean, it was very well orchestrated. Everybody was very compliant. They stayed where they were supposed to stay for sitting and socially distanced, and I think mask compliance was extremely good. And to my knowledge, we only had one fan removed for refusing to wear their masks. So I was really pleased with how that part of the football
That's
game
great.
went.
Yeah.
But I think we learned a lot from that we will continue to figure out how to do more things safely. But it's been a learning curve all along the way, and I totally agree with Chris. We gotta stay diligent if we're going to get through the rest of the semester.
Yeah, there you go.
Yeah, absolutely. I think the question we had about how do you know if it's coronavirus or another respiratory virus, we are in respiratory viral season now. It will be very difficult to tell if there are any questions or concerns. The best answer is to go out and get tested, and while you're waiting for your result, isolate yourself.
So tomorrow, one of our own nurse practitioners joins to tell her story of the whole family coming down with COVID-19. How could this happen when she's practicing and preaching the pillars of infection? She tells us her cautionary tale tomorrow. Here are a couple of photos. I probably won't say this right. I'm sorry if I don't. Chavley and Trish sporting their KU masks while meeting up to get their flu shots. Perfect timing. Hey, Dr. Hawk and I are going to be getting some flu shots right here on our update on Wednesday morning. You don't want to miss the pain that we get to receive because we want everybody to receive it. It's just right. Please remember to show us how you're going to incorporate your mask into your Halloween costume. If you plan to trick or treat or haunt or go to a haunted house, we want you to be safe. Remember, pretty soon you're going to get to hear about 50 ways to leave your mask, or love your mask, not leave your mask. 50 ways to love your mask. And go out the back, Jack. Make a new plan, Stan. Keep your new mask on. Just making sure it's clean. I could do this,
That's
people.
good. There we go.
Not bad, right? Not
I like
bad.
it.
So, those pillars of infection control, where you're the president of the United States, the quarterback of the New England Patriots, a member of the Kansas City Chiefs, the president of Notre Dame. No matter what you're doing, those pillars of infection control, they're real, and they follow you wherever you go. So just remember, wear a mask, keep your distance. Wear a mask. Keep your distance. Wear a mask and keep your distance. We can keep each other safe. We're here tomorrow. We'll see you then.